If we think about atrial chambers, we've talked about this a little bit already, but they're really defined by the appendage. So the left atrial appendage is long and thin versus the right atrial appendage is short and stubby. When we think about situs, that's really thinking about in relationship of the liver, the stomach, the spleen, the lungs, and the atrium. And the one thing to remember when you're looking at imaging is a right atrium goes with a right lung and a left atrium almost always goes with a left lung. And you can get really weird anatomy where you have two right atria, two left atria. Go look at your lungs and you'll start to see like fellows will all the time come up to me and be like, hey, people are like, is this right? Like there's actually two left lungs or there's two right lungs. And that's absolutely true. You can have that. And that's just based on what are your atria. So go back and look at your atria and you may see that you have two right atria or two left atria, or sometimes they're flipped. So what's on the left or right can be opposite. And so just one of those kind of fun anatomy things, but it is something that you'll see consistently. And then you have to define like where is the position of your liver and your stomach, so that abdominal situs is also important in relationship. When we think about ventricles, the right ventricle typically has coarse trabeculae. It has an apical moderator band, and then the papillary muscles attached to both the septum and the free wall, versus the left ventricle is kind of more thin, delicate. The septal surface is typically smooth, and the papillary muscles are only attaching to the free wall. The one thing that people do get, there can be like a false band in the left ventricle, so you have to be a little bit careful if you're just using the moderator band because you can get yourself confused with that, but that's kind of the generalities. The other thing we can look at is the mitral and tricuspid valves. So our mitral and tricuspid valves delaminate from the ventricle. So if you can't figure out your ventricle, but you figure out your valves, you figured out your ventricles, and vice versa. So the mitral valve always goes to the LV and the tricuspid valve always goes to the RV. And that rule doesn't get broken. So that's something that can be helpful sometimes. If you have a common valve, then it's called a common AV valve. And so you have a subsystemic AV valve and a subpulmonic AV valve. Looping of the ventricles is a little bit more complicated than what we can do in a very quick talk. But there's L looping and D looping, and so we define that. The great vessels, so the aorta almost always gives rise to the coronary arteries. You can have the anomalies, but at least your main coronaries are coming off of the aorta. And the coronary arteries follow the ventricle. So the right coronary artery supplies the right ventricle, and the left typically goes with the left ventricle, even if they're anomalous in terms of where they're coming off of. Now, for a systemic right ventricle, you'll often, when you're looking at your coronary arteries and you look at your left main or your LAD, you'll see that it's sending off like extra vessels that go to the right ventricle. So with a systemic RV, you'll still have the left main and the LAD going to the LV apex, but often it's giving extra vessels to the systemic right ventricle. Whereas your pulmonary artery is going to supply the blood to the lungs. So when we think about the arterial valves, again, the aortic valve is associated with the aorta. The pulmonary valve is associated with the pulmonary artery. Sometimes we do things in cardiology or surgery where we move the valves around. And so if it was a native pulmonary valve and now is in the aortic position, it's then called a neo-aortic valve. And similarly, if an aortic valve goes to the pulmonary position, it's a neopulmonary valve in terms of just terminology. The great vessels, when we think about their position, soleus, so this is our normal position of our aorta and our pulmonary artery. It can be inverted. So we have our aorta and our pulmonary artery. They can be transposed. So we have D-transposition here where we have our aorta and our pulmonary artery, or we can have L-transposition and then malposition also. And so this is just a nice little reference if you're thinking through, but you also have to kind of follow where does the blood go. Then we look at how do we put everything together from a connection. So concordant just means that they're connected correctly. that we're used to for our normal anatomy versus discordant means that they're not connected correctly. L transposition is the most common discordant AV connections that you'll see that can make it to adulthood because the other types of transposition or detransposition, often without surgical correction, won't, except for in some very rare cases, show up as adulthood. So L transposition is the most common that you'll see. Sometimes you can't tell, and so again, it gets ambiguous, and that's really when we're into the heterotaxy. You can have double inlet is the most common for like univentricular heart disease. You can also have absent or connections, and the most common for that would be like with a tetralogy of flow with absent valve, but those patients typically have already been corrected before they become adults. So ventricular arterial connections, it's exactly the same thing in terms of concordant, discordant, and then we look at all of our associated malformations. So ASDs, VSDs, stenoses, is it the correct size? Is it not the correct size? And then the other important thing to know is what are the associated malformations? And again, that's beyond what we can go over, but the guidelines in terms of the adult congenital guidelines, both the 2018 and then our most recent 2025 updated adult congenital guidelines do go over a lot of the different associations. If you need a quick review, and now with the advent of AI today, you can very easily also put in to AI in terms of like as a reminder, if you're seeing something being like, is there something else that I should be looking for? You can ask and really have it in real time and not even have to go look up that information, but just know to look for associated stuff if you're finding congenital heart disease. So the main thing is you just need to do it systematically. And if you do it the same way every time, you'll never miss anything. So with that, let's do some cases. And I think that's the most helpful to really think through what we're doing.